Hi. Okay, so I'm going to make a video and narrate my talk that I wanted to give you guys about acute coronary syndrome and the introduction to talking about acute MIs. I've never tried to make a video during the middle of the day while there's a bunch of classes going on and students. I'm usually here on the weekend or late at night when there's no one here, so it's a little weird. There's all these people going by and they're going to see me talking to myself in this classroom. Maybe someone will come in. We'll see what will happen. So we'll give this a try. So we're going to talk about ACS 101, acute coronary syndrome, assessment, diagnosis, and treatment of acute coronary syndrome. So kind of give us the basis. Why is it such a big deal? Because if you understand acute coronary syndrome, you're going to be able to impact a lot of different people because it's such a widespread disease process, especially in the United States. You're going to impact a lot of patients. We see a ton of patients that fall into this category of acute coronary syndrome. So what is it? I'm talking about angina and MIs, so chest pain that has to do with your coronary arteries and the blood flow that's going to your heart. And what is causing this chest pain, these changes on the EKG, and MIs that ultimately occur? It has to do with a balancing act between your MVO2 and your DO2. Your MVO2 is your myocardial oxygen consumption or your myocardial oxygen demand, and your DO2 is your oxygen delivery throughout your heart. So myocardial oxygen consumption or myocardial oxygen demand has to do with how big your heart muscle is, how hard it's contracting, how many contractions per minute, so it has to do with your heart rate. So when your heart rate is higher, your MVO2 goes up. When it's contracting harder, you have more MVO2. When you're playing sports or doing an activity, the oxygen demand goes higher, right? So that's when people have chest pain. So those are things that could increase your myocardial oxygen demand. And of course, when you're at rest, when your heart rate is lower, then these are things that will decrease your myocardial oxygen demand. And then how much oxygen can you deliver? Well, first of all, how much oxygen do you have available? How saturated are your hemoglobins? How much oxygen is getting off your hemoglobins to go over to the tissues? How good is your cardiac output at delivering that around your body to the tissues? How open are your coronary arteries? So specifically to bring those oxygen molecules back to the myocardial tissues. So those are the things that play a role in your oxygen delivery. So it's all about supply versus demand. That's what acute coronary syndrome is really all about. So myocardial ischemia is going to be you're starting to get starved for oxygen. And if you need more than you can get, then you're going to get ischemic, and we call that angina. So, or angina pectoris. So that's going to be causing some ischemic chest pain where people start to have a little bit of substernal chest pain would be classic, so right here below the sternum. And of course they would get it more at times when they're active because the myocardial demand for oxygen is higher during that time. Injury and infarction. So ischemia is where the cells start to get a little starved for oxygen. They need more than they're getting. Injury is where the cells are now starting to have a real impact or injury. And then infarction is where they break open and necrose and die, and those cells are not coming back, and that's an MI, and that tissue's not coming back anymore. And myocardial infarctions can be divided into two types of events: ST elevation MIs and non-ST elevation MIs. So now we're talking about looking at the 12 leads. When we look at your EKGs, are you going to have the type of infarctions that cause the ST segments to elevate in a localized part of your 12 lead, or they do not cause the ST segments to elevate? And that is going to have to do with whether the injury goes full thickness through part of your left ventricle or it is not full thickness through part of your left ventricle. That's what we'll learn about when we learn to read 12-lead EKGs. All right, so our goals in managing acute coronary syndrome is to recognize that someone could be having ischemia, injury, or infarction, to recognize it right away, how to diagnose if somebody could possibly be having an MI. So recognition and diagnosis, we have to know the clinical signs and symptoms, but one of the things that's really important is differential diagnosis, because there's other things that make people come into the hospital with chest pain or chest discomfort. That is not an MI or not related to angina, to cardiac ischemia. Like if somebody punched me in the chest, my chest would hurt, but that's not related to a heart attack. So that's differential diagnosis. We want to know about EKG changes because that's really how we diagnose an MI or cardiac ischemia. And we need to know about different diagnostic exams that are used. So EKG is one diagnostic exam, but how about echocardiograms? How about CTs of the chest x-rays? Here's some other diagnostic exams, and also laboratory work. Our next goal is to do rapid treatment. So first we just want to stabilize them, control their symptoms, but then ultimately our goal is we've got to do something to get oxygenated blood back to that hypoxic region of the heart. That's when we're going to take them to cath lab and try to reopen that clogged vessel and get some oxygenated blood back to that part of the heart. Now the cells that have already died and infarcted, they're gone. We can't get them back. But the ones that are just in the injury state, we can possibly get back. And the ones that are ischemic but not yet injured, we can definitely get back. So those are our goals, is to recruit the ones that are ischemic and injured. The ones that are infarcted and dead, we cannot get back. So first we just want to stabilize them so they don't code on us and die. So we stabilize them, control their symptoms, and then we got to get a reperfusion strategy, usually to take them to the cath lab. And then maybe some people will have to go for open heart surgery and have a bypass graft to get oxygenated blood back to the heart. And then, so we recognize and diagnose, we do our treatments, we get blood back to the heart, and then we have to do follow-up treatment for that person. So our follow-up treatments, we want to minimize the complications and optimize the outcomes for them, both in the short term and the long term. Okay, so we're going to look, that's going to be a lot of medications and also things like smoking cessation, lifestyle changes. So those things will be in our follow-up treatments. All right, so let's figure out how we're going to do it. One of the first things that we have to understand is what really happens to people when they have an MI. So what happens is that you have a bunch of plaques that are inside of your coronary arteries. I don't mean you personally, so like don't take this personally, but maybe not you, but a lot of people have plaques inside their coronary arteries. So let's take a look at your coronary arteries. All right, let's see. I think we might need a little light. So let me pause for a second here. All right, so here's the heart sitting inside your chest. It's flat on the bottom. Here's the apex of the heart down here. It's shaped like a football. And inside your heart, it's going to be tipped forward like this, a little bit to the left, and it's twisted so that the right side is in front of the left. It's a pretty good strategy, actually. So if anything were to hit you in the front of the chest, it's more likely to damage the right side of your heart rather than the left, which is more protected. That's good news, right? Because you really need the left side of your heart to keep pumping. Even if everything on the right got crunched and didn't work anymore, as long as you had your left ventricle working, you'd be okay. And speaking of left ventricle, one of the things I want you to know is you look at this whole heart right here, Most of this mass, most of this meat of the heart is your left ventricle. Most of the mass of your heart is your left ventricle. Because you got to remember that your left ventricle is your big squeezing pump, right? It has to pump blood. Every time it pumps, it has to pump blood all the way from the top of your head down to your toes, to every organ in your body. So it has to be a big, powerful pump, and it has a lot of muscle mass. It's a pumper. Your right ventricle is just kind of laying on top like more of a flap. It doesn't have nearly the muscle mass, because when it pumps, it's more like a flap. It just has to get blood from your heart just right over here to your lungs. It doesn't have to go very far. So it's a low pressure system. The left side of your heart is a high pressure system. It has to generate high pressures to shoot the blood out all over your body. Right side is a low pressure system. So most of this heart is your left ventricle. It has several different areas. It's so big we name walls of the left ventricle. This whole front part right here is the anterior wall of your left ventricle. The side over here, kind of by the left armpit, this entire left side of the heart, this whole meaty part, is the lateral wall of your left ventricle. And underneath here, where it's kind of flat on the bottom right here, this flat part that just sits on top of your diaphragm like a shelf, underneath, it's the inferior wall of your left ventricle. Now, a lot of times you probably heard people say, oh, they had an anterior wall MI. They had a lateral wall MI. They had an inferior wall MI. So they don't really just mean like the anterior wall of your heart. Well, they do, but it's the anterior wall of your left ventricle, because that is most of your heart. So where is your right ventricle? It's here. It's like a flap that's on top. It's just here. But here's the anterior wall of your left ventricle, the lateral wall of your left ventricle, the inferior wall of your left ventricle. Here's the posterior area of your heart. It has a little bit of muscle mass, but mostly it's a bunch of great vessels and stuff. You can have an infarct in the posterior area of your heart, but you don't lose much of your left ventricle, so it's not a very big type of heart attack. In fact, they usually get missed. You discover it on EKG changes, not because the patient even really has very many symptoms. All right, so these are the three big areas of your heart, or really of your left ventricle, where you could have an MI. The anterior wall, the lateral wall, which is on the left, or the inferior wall. And you have some big coronary arteries that feed these three big walls of your left ventricle. Coming right down the front, coming straight down the front of the anterior wall of your left ventricle. See the red? So for every artery, there's also a vein that follows it. That's why you got the red and the blue. Coming straight down the front of the anterior wall of the left ventricle, you have the left anterior descending artery, LAD, right there. It's a biggie. It feeds the biggest wall of your left ventricle, feeds this whole anterior wall. Over here on the side, the lateral wall, you have a big old coronary artery that kind of flexes around the side. We call it the circumflex. It feeds the lateral wall. Okay, so circumflex, LAD. Circumflex feeds the lateral wall. LAD comes down the front, feeds the anterior wall. And these two big coronary arteries come from the same spot that come off your aorta, right here at the top. So for a little bit, they're the same artery. Then they bifurcate into the LAD at the front and the circumflex going around the side. This little part at the top where they're the same artery before they bifurcate into the LAD and the circumflex, this is called the left main. All right, so if you were to have a plaque in your LAD, and plaques love to form where there's bifurcation. So you have a lot of diagonals coming off of your LAD, going to bring blood to all these different muscle cells, right? All this part of the myocardium. Plaques love to form where there's bifurcations because this is where there's a little bit of a disturbance in the blood flow. You get a little bit of swirling, a little bit of slowdown, right? So if there's any kind of sediment or anything, cholesterol, piece of a French fries going by, whatever, there's a little bit of a swirl, that little piece of a French fry is gonna, sediment will settle right there and a plaque will start to build up. That makes sense, right? Just like a river that has a turn, sediment will start to fill up right there and a plaque will form. So plaques like to form where there's bifurcations. So if you have a plaque right here, this is where the blood is getting skinny in there. It's having trouble getting by. So you have some plaques building up at these intersections. As long as you're at rest, it's probably enough blood flow. But when this guy tries to go out and mow the lawn and it's hot and he has increased myocardial oxygen demand, it's not quite enough oxygenated blood flow to this big wall of the heart. And he starts to get a little bit of ischemic chest pain, right? Okay. So if he had some plaques in this coronary artery, the LAD, he might have a little bit of EKG changes that would show us ischemia to the anterior wall. You have some diagonals, especially one big one coming off of the circumflex over here. And so you might have a little ischemia to the lateral wall of the heart. You have one more really big coronary artery. It comes off the other side of the aorta. So here's the left main going into the LAD and the circumflex. Here's the other side of the aorta. And it's going to go just below the right atria. Hug the right atria, come underneath to the inferior wall, make a 90-degree turn, head down to the point of the football down here. So this is the right coronary artery, the RCA. Comes under the right atrium, goes along the right side of the heart, underneath to the inferior wall, makes a turn, heads down to the apex of the heart. Feeds the inferior wall of the heart. So here's your RCA, goes along the right side underneath, feeds the inferior wall of the heart. LAD feeds the anterior wall. Circumflex feeds the lateral wall. RCA goes under, feeds the inferior wall. So what happens when we have an MI? You have a plaque. That plaque can get unstable and rupture. So a plaque by itself can cause some ischemia, but it's not causing the MI. What happens in the MI is the plaque ruptures, and that stuff is exposed to the bloodstream, and it calls platelets to the area. And the platelets form a clot that blocks off that coronary artery. When the clot forms and blocks off this coronary artery, everything downstream of here no longer gets any blood flow. That's an MI. What causes that? What causes that plaque to rupture? That's one of the things that a lot of studies are aimed at, because a lot of times it happens around 4 or 5 in the morning, so a lot of people think circadian rhythms are involved, or cortisol spikes, because they follow your cortisol levels. So you know, like early in the morning, your cortisol goes back up to help wake you up. So people look at that, inflammatory processes, all sorts of things. Some plaques are more unstable than others. It's the plaques that have a lot of this inside toothpastey consistency stuff that are the unstable plaques. These are the ones that like to rupture and cause MIs to occur. Some people have more hard plaques. Those are less likely to rupture and cause an MI. Some people are full of toothpaste-filled plaques, and I just say like the consistency inside is like toothpastey. I'm not saying they're actually full of toothpaste. They're really full of French fries. Those are the ones that are more likely to occur and cause MI. So like higher your cholesterol, the more full of stuff like that those plaques are. So what were to happen if you had one of these toothpaste consistency, highly, more likely to rupture plaques, and it was on your LAD, it was down here about 2/3 the way down, at one of these bifurcations, like where you had something coming off right there, and it were to rupture, a clot forms, and then that means from here down, no blood flow. So you infarct from here down. So you'd have an anterior wall MI. But it's not that big, right? So you'd have a person would have some chest pain, they'd have some EKG changes or STs go up, they'd have some positive cardiac enzymes, they'd have shortness of breath, they come into the hospital, we do all the things, they'd probably be all right. They'd recover. But what if the plaque was more proximal to the aorta, all the way up here? And then everything from here down on the anterior wall didn't get any blood flow. You infarcted almost all of your anterior wall. Well, the anterior wall is by far the biggest wall of the left ventricle. Once you lose 40% or more of your anterior wall, you're at very high risk of going into cardiogenic shock. So that person would probably go into cardiogenic shock. They might not be able to have enough stroke volume or cardiac output. They might code. They're going to go into ICU, be on a bunch of drips. They might have suddenly go into VFib or something. So that person is at a lot more risk of sudden cardiac death from their MI. What if you had a plaque over here that ruptured and you didn't get any blood flow from here down on the lateral wall? So that would be a lateral wall MI. That's not so big. You still have your whole anterior wall. You still have your whole inferior wall. You still have pretty good squeeze. So a partial lateral wall only MI, that's a smaller kind of MI. It's not so bad. If you infarcted your entire lateral wall, it's a little bit bigger. Let's look at the inferior wall. It's pretty big, so you could have, if you had one that was pretty proximal, like here maybe, infarct most of your inferior wall, you'd have quite a few symptoms, but it's still not nearly as bad. Excuse me, my valve fell out. Still not nearly as bad as an anterior wall MI, because as you can see, this is the biggest wall of the heart, for sure. What if you had a plaque at the bifurcation of your left main, right here, and it ruptured and a plaque formed, and you infarcted your entire anterior wall and your entire lateral wall? That would be an anterolateral MI. You got hardly anything left. The only thing that would be trying to pump is your inferior wall. That's not going to be enough to keep anyone alive. An anterolateral MI is about the biggest MI that there is. If somebody is starting to build up a plaque right here, like we take them to cath lab for a diagnostic angio, and they see that they're building up a plaque right here, we call that one the widowmaker. So they will go, we cannot balloon plasty it, we can't blow up a balloon in here because you can't block off all circulation for any amount of time. So they will go to open heart surgery and have bypass surgery to fix that. Because if at any time it were to rupture and infarct, those people will usually have sudden cardiac death. That's like in the movies where people suddenly grab their chest and fall to the floor and they're dead from a massive sudden heart attack. That's probably the widowmaker of the left main. So that one's no good. All right, I do have some more slides, so I guess I better get going on these. Because we are at 24 minutes. All right. So the plaque ruptures, you get erosion of the fibrous cap, clot formation, and you can get either partial occlusion of the blood vessel, where a little stream of blood is still going through. Then you might have a non-STEMI, where all the tissue doesn't die and the STs don't go up, but you still have some positive enzymes, cardiac enzymes. The patient still has some symptoms. So if they have positive cardiac panel, CKMBs, troponins, we would say they did have a heart attack, but the STs didn't go up. Then we know some trickle of blood was still getting around that clot, and maybe it was only a partial thickness necrosis that occurred to the wall of the left ventricle in whatever location they had the clot. And then, so it was not a full thickness MI. But if there was clot formation and complete occlusion of the lumen and everything from downstream died, then that is an ST elevation MI. All right, so here's some cadaver pictures. So here's where there's a clot, the plaque ruptured. Here's some of the stuff that came out from the plaque. And then here's clot formation, but they still had an opening. So this person had a non-STEMI. Likewise here, here's the clot. They still had an opening. They still had an opening, but here's total occlusion right here. So this is a full STEMI. All right, signs and symptoms. So how are we going to recognize them? Classic angina pectoris, classic symptoms. Whoops, I don't think we're seeing the whole thing here. Here we go. Classic symptoms is deep, so where it feels like it's underneath your sternum, deep substernal, poorly localized. So if you say, where does it hurt in your chest? They go, right here underneath my shoulder. Then that's probably not cardiac chest pain. That's probably musculoskeletal pain. So it's going to be like more in this whole area, poorly localized. Squeezing, like typically they say, feels like there's an elephant on my chest, feels like there's a steel band around my chest, and I can't take a breath, it's just pushing in. Heavy, tight, may radiate to the left shoulder, down the left arm, up the left side of the neck, into the left jaw. That's classic because of the way that the nerve endings in these areas are also being supplied off of some of the blood supply that's being affected. But not everybody has this. The people most typical to have this are going to be adult males having an anterior wall MI. But there's plenty of other people having heart attacks. Women are less likely to have these symptoms. People with inferior wall MIs frequently come in complaining of gastric symptoms. So they're nausea, vomiting all night and thought they had some horrible gastritis. And they took Maalox and Tums all night long and delayed coming to the hospital. Very typical for inferior wall MIs. Anterior wall MIs tend to be very big heart attacks, harder for people to mistake for a stomach ache. Women tend to have atypical symptoms. Diabetic patients don't usually, a lot of times, do not experience pain in the same way because of neuropathies. So if you say, do you have chest pain? No. You have to ask some other questions. Do you have shortness of breath? Are they cold and clammy? Do they feel pressured? Do they have a fullness in the neck? They might have other things, but they'll never say yes to chest pain. Other classic signs and symptoms. Shortness of breath, nausea, vomiting. Almost everybody with a MI throws up. Weakness, anxiety, and definitely feelings of impending doom, for sure. They're sweaty, dizzy, and then of course sudden cardiac death. That's a pretty good sign that they're having a massive MI. That's probably an anterior wall. Not typical of pain from an MI. So here's things that are probably not an MI. Pleuritic pain. that means coming from something relating to your lungs. So if it's worse when they breathe in and better when they breathe out, so related to the respiratory cycle, that's probably not an MI. If it's worse when they lay down, but better when they sit up in tripod position, that's probably related to lungs and pleurisy and not chest pain. Chest pain is not positional, doesn't get any better depending on if they lay on their side or sit up. If the pain is solely or primarily low or mid-abdomen, then that's probably not chest pain. Now, it is true that inferior wall MIs come in complaining of gastritis, but if it's only here and they don't also have shortness of breath, cold and clammy, squeezing, fullness of the neck, and some other symptoms, if it's only this, it might not be an MI. But we're going to get a 12 lead and we're going to get a cardiac panel. So we're going to diagnose them. Stabbing pain of short duration, especially if it's showing up here between the shoulder blades, that sounds like an abdominal aneurysm. Pain that can be localized with a fingertip. It really hurts right here. Ow, 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 don't touch it. That's musculoskeletal pain. Pain that radiates to all extremities, not just to the left side, is not usually typical MI pain. So that sounds like neuropathy. Aortic dissection, that's going to be a stabbing pain, stabbing here, but frequently stabbing between the shoulder blades. PE, pulmonary embolism, we talked about briefly, but hurts a lot with trying to breathe in deep, and also SATs are dropping and refractory to oxygen. Pericardial effusion with tamponade. It is, so we talked about that a little bit in class as well. It is positional. It is worse when you breathe in, and we can diagnose it off of an echo or chest x-ray or a CT. Tension pneumo also will be positional, related to breathing. They'll have signs of respiratory distress. Esophageal rupture, they're going to have GI bleeding that goes with that. And then musculoskeletal pain. Here's one thing. So like Tylenol, Advil, stuff like that won't touch coronary pain. So if they said they took an Advil and they got some relief, it's not from an MI. That only works on musculoskeletal pain. Atypical presentation. So presentation will vary based on if it's an anterior or an inferior. Anteriors tend to be really big MIs. Inferiors tend to be smaller MIs. And the severity, and we did talk a little bit about women diabetics, and also older people don't always report as intensive pain, but it varies. We can't make a sweeping generalization about all older adults, but they may not come in reporting as intensive pain, or they just might not report it to you, so you have to ask the right questions. All right, here's what we're going to do. As soon as we suspect that somebody's having an MI, we get the 12 lead immediately. And even if the first one doesn't show us the diagnostic changes for MI, the patient's continuing to have symptoms, we get serial 12 leads. So we do one in 30 minutes and we do another one in 30 minutes. The average time it takes for ST elevation from the time they start having chest pain was like, well, it just went out of my head. I think it was like 38 minutes. So if you were, let's say you're on the floor for somebody who's there for chest pain, rheumatoid MI, and they got their cardiac panel and it was negative, so they didn't have an MI, they're just having like ischemic chest pain. And they're supposed to have go to cath lab in the morning for a workup. But in the night, they start having chest pain. So you go in, you give them some oxygen, you take vital signs, you call for a 12 lead because you're worried because they really are having a lot of chest pain. And you're on it like that quick. The first 12 lead comes back, they do not have localized ST elevation, so they do not look like they're having an MI. Should we just leave them alone for the next 4 hours? No. If they continue to have chest pain and they continue to be in distress, we get another one in 30 minutes because maybe this time the STs will be elevated and localized. And then we have our MI. So they don't always go up immediately in the first 2 minutes. It can take like 38 minutes. I think that was the average, but it could take like 30, 45 minutes till those STs go up. So ST elevations localized, which is what we're going to learn to look at on a 12 lead, will diagnose an MI. ST depressions localized will diagnose ischemia. T-wave inversions can be meaningful for ischemia if they did not have a bundle branch block and now all of a sudden their QRSs have gotten wide. They didn't go into VTAC, so they're not in a ventricular rhythm. They're still in like sinus rhythm, but their QRSs have gotten wide. They have bundle branch problems now. That can be indicative of possibly an MI. So those are all things we'll look at for on the 12 lead. So we're going to get the 12 lead right away. Then we're also going to get a cardiac panel. And we're going to look at the CKMBs. We can look at myoglobins, but especially CKMBs and troponins. Doctor might ask to get an echo. It is not diagnostic, so we don't wait on anything for an echo, but especially if they suspect problems with valves, then an echo is very nice for that in particular. And then we can get a chest x-ray. It does not diagnose, obviously, anything about an MI, but it's good for differential diagnosis. So if they think it's maybe not an MI, could it be some other thing, then they might ask to get a chest x-ray. All right. Let's look a little bit at some EKG. Okay, I gotta pause for just a sec. You guys hanging in with me? I know it's a lot, but it's good that it's on video because then you can pause it and go back and stuff. And we're gonna learn to read EKGs. And what we're gonna look at is we're gonna look for these elevations or depressions and or T-wave inversions, but we're gonna look for them all in one area. So we're gonna look for the changes, but all in the leads that only look at the anterior wall, all in the leads that only look at the lateral wall, or all in the leads that only look at the inferior wall. And if they're localized so that all the leads looking in one area have these changes, then we have diagnosed an MI or ischemia. So here is some ST elevation. So we've got the P wave. Let's see, does my thing show up? I don't know if we can see it. So we've got the little P wave. There's one P for every QRS, and the PRs all look the same. So this person is in sinus rhythm. Here's the PR intervals. They all look the same. So it's sinus rhythm. Here's the QRS. It ends way up here in the air. Here's the ST segment, and then a very tall T wave that is much higher than the QRS even. So ST segment is just going straight up in the air, very elevated. And they say that this pattern kind of looks like a fireman's hat. It's like an old-fashioned fireman's hat that's like the front is flat, and then that hat goes back like this. I don't know if you even know what I'm talking about, but like an 1800s fireman's hat on this way. So when you see this old-fashioned fireman's hat like that, very elevated STs where the QRS ends way up here. QRS begins way down here, ends like 4 boxes higher than it began. So like 4 boxes of ST elevation. That's a lot of ST elevation. This is telling us that it's the point of view that we have on this strip is V6. So we're no longer looking in lead 2 because we're now starting to move into the world of 12 different leads, not just lead 2. So something like this on a 12 lead could indicate an MI. ST elevations can indicate an MI. So to remind you, here's the ST segment. The other thing that we could find if we don't see ST elevations is we could see ischemia, and there's 2 changes that can be ischemia. One is ST depressions, where the QRS begins on this line, but then it ends lower. So the ST segment is lower than the isoelectric line. So if these changes are localized, all the leads looking at one area have this change. ST depressions localized can be ischemia, or just the T waves are upside down. Or you can have both. ST is depressed and the T wave is upside down. So ST is depressed and or T waves upside down can be ischemia if it's localized, and ST elevations can be MI. Okay, so here's a huge ST elevation at the very top in box A. And we're starting to get what we call a Q wave right here, where the first wave going down, which is a Q, part of the QRS, is starting to get very large. In box B up here at the top, we have ST depression. And then in box C at the top, they're showing you T wave inversion. So box A is ST elevation, that could be an MI. Box B, ST depression, that could be cardiac ischemia. Box C at the top, that is T wave inversion, that could be cardiac ischemia. Okay, right here we're just looking at some really, really big ST elevations. So the person is in sinus rhythm, they have P waves and they have ST segments, PR intervals. We don't have a lot of beats to look at, but we'll assume it's sinus rhythm. But they have huge ST elevation. It looks like it ends about 1, 2, 3, or yeah, it ends like, QRS starts here, ends like 1, 2, 3, 4, almost 5 boxes of elevation higher than where the QRS took off from the line when it went down. So a lot of ST elevation, this could be a big MI. Here again, the QRS takes off from the line here, goes up, down, up, ends all the way up here. So you have about 2 or 3 boxes of elevation. Here's the ST segment. All right, let's talk about cardiac markers. So I put a really nice summary. It's in the module for you guys to look at that kind of explains the important points of the biomarkers that we find when we get a cardiac panel. We have myoglobin is a substance that's released from all sorts of muscles in your body when they're damaged. Myoglobin is not very specific because skeletal muscles also have it. So it's good because it's released quickly and you can definitely tell there's been damage, but it's not real specific to your heart is the problem. CKMBs are nice because they go up and then they come back down. So what we like about CKMBs is like if you had, let's say, a balloon angioplasty and a stent placed, and then later a problem people have is they can get a clot that reoccludes their stent, and they can get a second MI. So they can get stent reocclusion. One of the things we want to know if somebody has a second MI or a second event, like a stent reocclusion, because CKMBs go back down pretty quickly, we can then redraw somebody's blood and see if that CKMB has gone back up. So what's helpful about CKMBs is that they go up quickly, but then they come back down, so we can see if they had a second event on a CKMB. Troponins are our most sensitive marker of an MI. So when we get a lab test, we love troponins because they're very, very sensitive for an MI. But they stay elevated for longer. So if they get better, but then later they have a second event, troponins are still up, so we wouldn't even see it with a troponin. So that's why we kind of like to have both things. And some places don't even draw myoglobins anymore, but a lot of places do still draw myoglobins. So I would like you to look, instead of explaining it a long time here, I'd like you to look in the resources and read about the different biomarkers that we draw on the cardiac panel. All right, let's talk about treatment. So what are the things we're going to do? We talked about we have to stabilize them and control their symptoms, but then ultimately the whole plan is we got to, as quickly as possible, get them someplace and get the blood back to the myocardium and save as many myocardial cells as we can because they're dying off, right? That's the goal. Tissue reperfusion, and time is money, people. We got to get in there and get them before more and more of the left ventricle dies. because that's going to determine how they live the rest of their life with whatever amount of left ventricle they have left. All right, so initially we assess them within 10 minutes. We get their vital signs, a quick history just related to what's going on. And one of the most important things we want to know, when did the chest pain start? And what's their cardiac history? Have they had an MI before? Are they already taking nitro at home? Like, these are the important things to know. Do a quick physical assessment, get their vital signs, find out if they're having chest pain. Get the 12 lead right away. The 12 lead is how we diagnose the MI. That's how we diagnose the MI, is off the 12 lead. And remember, if the first one doesn't show it, they're continuing to have symptoms, we get another one in 30 minutes and we can keep getting them. Serial 12 leads if we need to. All right, let's do our quick treatments. Mona. And we're going to talk more about Mona in class because I know some places are like, we don't really do traditional Mona anymore. But we still do use all the elements of Mona. So we're going to give them oxygen. And some places have kind of gotten more conservative with their parameters, saying not 100% on everybody all the time. But let's keep them above like 94% or 95%. So we'll talk a little bit more about that. I would say I'm a lover of oxygen. If I'm having an MI, I would really like to get a lot of oxygen because most of us without lung disease, like COPD, are probably walking around at 98, 99% on room air. And so I would really not like to be 94% while I'm having my MI. I'd like to be 99 or 100% while I'm having my MI. But I don't know, anyway, we'll talk more about it in class. But we're going to definitely give them oxygen because it's one of the things they need very, very badly. We got to make sure they have excellent IV access because they're going to need a lot of medications right now. If they go into cardiogenic shock, they're going to be on multiple drips. So let's get that started right away. Get them on the heart monitor. So we are going to do Mona, but we're going to keep in mind all the newest evidence, which we'll talk about a little bit more in class. Mona is morphine, oxygen, nitroglycerin, and aspirin. And we still do give all those things. But morphine, we're going to use judiciously because it can lower people's blood pressure and we need to keep enough blood pressure. But it vasodilates the coronary arteries, which is helpful. It decreases their heart rate, which decreases myocardial oxygen demand. It decreases anxiety. It decreases feelings of impending doom. There's so many reasons to love morphine. I just love giving MI patients morphine. But I do realize it's out of vogue at the moment, but I say don't take it off the table quite yet. Nitroglycerin is a drug that vasodilates. We're going to talk more about nitroglycerin, but one of the things that we don't want is for somebody to be peripherally vasoconstricted while their poor, ailing, infarcting left ventricle is squeezing as hard as it can to get any blood to move forward into circulation. We need it to be so easy to get blood to move forward out of the left ventricle that it hardly has to squeeze at all, because that will bring the myocardial oxygen demand very low. And that's one reason we use a little nitroglycerin. But we also have to make sure they have blood pressure. So it's always a little bit of a balancing act. Aspirin, you're probably saying, aspirin, that's so old-fashioned. Yes, but there's unbelievable evidence that giving people aspirin, they have much better short and long-term outcomes. And then we begin a reperfusion checklist, and that's usually about getting them to the cath lab. So we look at the 12 lead and we decide, is it normal? Do they have ischemia, or are they having an MI? Those are basically the three categories that we're going to put their 12 lead in. And we decide, are they going to get an angioplasty in the cath lab? That's a PCI, a percutaneous intervention. If we do that, we want it within 90 minutes from the time they hit the door of the ED. Or is there some reason they cannot have that, like we're at some little rural hospital where we don't have a cath lab on call, in which case we have to give them a clot-dissolving drug, like streptokinase, but not everybody can get it, because if they had a stroke ever, they're not allowed to have it. There's a lot of different things that rule them out from being allowed to have a drug like that because they're too high of a risk of getting a head bleed. So we'll talk about that, fibrinolytics. And then if they do get a drug like that, we put them on a heparin drip to prevent clot reformation. But most everyone, we're trying to move them to the cath lab. Stabilize them, give them Mona, stabilize them, move them to the cath lab. So we evaluate them, get the 12 lead and diagnose them, stabilize them, move them to the cath lab. Get the 12 lead, stabilize them, give them Mona, move them to the cath lab. That's what we're trying to do. All right, so we're giving them oxygen, nitrates, that's nitroglycerin. Other things we can give are beta blockers. What are they going to do for you? Lower your heart rate, decrease force of contraction. Why is that helpful? Because there's two ways to bring down myocardial oxygen demand. So that's really going to balance the seesaw for somebody and maybe decrease the infarct that's occurring or the angina that's occurring. We can put them on anticoagulants. After their MI, they're definitely going to be on an anticoagulant. They're going to be on an ACE inhibitor, and they're going to be on a statin to bring down all that cholesterol that's forming all those plaques. All right, we're going to take a break before the next part. All right, we're getting close. We're going to talk about some treatments and a couple of patterns, and then we're done. So I know this is a biggie. Let's talk about nitroglycerin. When we put it in a continuous IV drip, the most commonly used trade name is Tridil, so we call it a Tridil drip, but it's a nitroglycerin IV continuous drip. There is a time that we do not use nitroglycerin in a continuous IV drip, and that is if somebody has a right-sided infarct. And we're going to talk about this more in class, because I know that it's going to be a little confusing to do not in person, but I'm going to mention it now, and we'll reinforce it in class. But here's what I want to say to you. What if somebody had a plaque in their right coronary artery? Oops, I'm getting a thing here. In their right coronary artery. And from here down, they infarcted their entire inferior wall. So they had an inferior wall MI.